So today we are presenting the diagnosis of prostate cancer. We start mainly focusing on PSA and prostate biopsy. The diagnosis basically depends on starting from the simple clinical examination, DRE, and varies with the spectrum with advanced imaging like multiparametric MRI. But our focus will be mainly on PSA and prostate biopsy. So Dr. Shersha will start in the presentation.
Assalamu alaikum. My name is Dr. Shersha, and I'm going to present this on a diagnosis of prostate cancer. It's in the continuation of series of lectures that we are going on this subject. So initially, we had three forms of PSA known: the pancreatic renal kallikrein, human HKLK1, the human kallikrein-2, HKLK2, and PSA HKLK3, which are serine proteases which show similar homology. But after that, almost 12 more groups of this kallikrein gene family have been known. HK2 and HK3, the PSA, are released in zymogen form from the prostatic epithelium and found in serum and semen. Zymogen form is the inactive form of an enzyme that is released. So from prostatic epithelium, the pre-pro PSA is released, which undergoes cleavage to form pro-PSA. The pro-PSA is a chain of 237 amino acids, which has additional 7 amino acids attached to it. HK2, the human kallikrein-2, acts on this pro-PSA to form PSA. This PSA exists as free PSA or complex PSA. We know that the PSA are more in concentration than the free PSA. Most of the PSA is complex to alpha-1 anti-chymotrypsin, alpha-2 macroglobulin, and alpha-1 protease inhibitors. Whereas the free PSA exists as the BPSA. BPSA is raised in the settings of benign prostatic hyperplasia and is more expressed in transition zone. If the pro-PSA has to undergo internal degradation to form this BPSA, and if the pro-PSA undergoes proteolysis, it forms intact PSA. The functions of PSA: it acts on the gel-forming proteins, semenoglin and fibronectin in the semen, and helps to liquefy it. So here you see this pro-PSA, which has 237 amino acids and 7 amino acid chains attached to it. So it has to go cleavage to form this active PSA. It goes internal nicks to form 4 pro-PSA, 5 pro-PSA, 2 pro-PSA, and such types are mostly found in the transition zone. Whereas if this PSA undergoes internal nicks or degradation, it forms BPSA, and if it undergoes proteolysis, it forms intact PSA. We should know that in the settings of prostatic carcinoma, the PSA usually does not undergo proteolysis and is mostly found attached to the alpha-2 microglobulin and anti-chymotrypsin forms. The PSA produced from malignant cells escape proteolysis more frequently. So a greater fraction of serum PSA compared to anti-chymotrypsin and a lower percentage of serum PSA. PSA that is free compared with men without prostate cancer. This principle led to the development of free PSA testing as a means to improve the accuracy of PSA as a prostate cancer screening biomarker. And the FDA has approved its use in men with a serum total PSA of 4 to 10 nanogram per ml and a negative DRE. In a prospective multi-institutional study of men aged 50 to 75 years with PSA levels between 4 and 10 and a palpably benign prostate glands, a percentage free PSA cutoff of 25% detected 95% of cancers, while avoiding 20% of unnecessary biopsies. So in serum, the complex PSA is about 60 to 95%. The PSA can attach to anti-chymotrypsin is 60 to 90%. The PSA attached to alpha-1 protease inhibitors is 1 to 5%. Alpha-2 microglobulin complex is about 10 to 20%, and free PSA exists about 5 to 45%. So we had just read that the free PSA cutoff to diagnose CA prostate is 25%. These are the conditions in which PSA levels may vary. Of course, carcinoma of prostate, benign prostatic hyperplasia, prostatitis, urethral instrumentation, perineal insults such as prolonged bike riding, it's said that usually more than 55 kilometers a day. Use of 5-alpha reductase inhibitors like finasteride reduces PSA levels by 50% after 1 year use. So if patients who are taking such drugs and come to you with a PSA level of 50, so you can predict that it should be actually 100 because it has drug effect on it. BMI, patients who are heavy, obese, usually have lower levels of PSA, maybe because of hemodilution, trauma after biopsy, and recent coitus. Normal PSA is said to be less than equal to 4 nanograms per ml. PSA between 4 and 10 nanogram per ml has a positive predictive value of 20 to 30%. Then that of PSA above 10 nanograms is 42% to 71%. However, there is no single normal threshold of PSA. PSA levels are elevated by approximately 0.12 nanogram per ml per gram of BPH tissue. In men without BPH, the rate of change in PSA is 0.04 nanograms per ml per year, compared with 0.07 to 0.27 nanogram per ml per year in men with BPH who are between ages of 60 and 85. Patients whose PSA increases by 0.75 nanogram per ml per year are at an increased risk of harboring cancer. So PSA is organ specific and not disease specific. Its half-life is 2 to 3 days. Ectopic presentation of PSA occurs in breast tissue, adrenal, and renal carcinomas. 70% of serum PSA is bound to 3 proteins, that is alpha-2 microglobulin, alpha-1 protease inhibitors, and alpha-1 anti-chymotrypsin. Patients with prostate cancers have a higher fraction of circulating PSA bound to these proteins, that is, they have lower free PSA. So PSA density, it is calculated by dividing serum PSA by the prostatic volume. PSA density is a method to differentiate benign versus malignant diseases. Higher PSA density values, greater than 0.15 nanogram per ml per cc, are more suggestive of prostate cancer. Lower values suggest BPH. An elevated PSA density has a sensitivity and specificity of 75% and 44% for predicting cancers on repeat biopsy. Prostate biopsy. It's the second domain of today's discussion. We'll discuss about indications, preparation, techniques, contraindications, some other types, and complications. So to go for a prostate biopsy, you have to do a transrectal ultrasonography. But there are some settings in which we do TRUS without doing the biopsy. For example, when you are planning for volume measurements, like for brachytherapy, cryotherapy, benign prostatic hyperplasia therapy. When volume measurement is done during hormonal downsizing for external beam radiation therapy or brachytherapy, placement of radiofrequency markers for external beam radiation therapy, evaluation of azoospermia, for example, ejaculatory duct cysts or seminal vesicle cysts, therapeutic aspiration or unroofing of prostatic cysts, drainage of prostatic abscesses. While these are some of the indications of initial prostate biopsy, initial diagnosis of prostate cancer based on informed decision making in an asymptomatic patient based on PSA and specific patient risk factors. Suspicious DRE findings to diagnose prostate cancer with symptoms suggesting the cancer, to diagnose prostate cancer with findings suggestive of metastatic disease, or in the settings of prostate cancer detected on routine transurethral resection of the prostate. Repeat biopsy is done in the settings of rising or persistently elevated PSA, atypical small SNR proliferations, or when you have extensive prostatic intraepithelial neoplasia, prostatic urinary prostate cancer antigen, or other newer genomic tests such as confirmed MDX methylation assay, suspicious lesions on prostate MR imaging, it is done to differentiate local recurrence versus systemic disease with PSA recurrence after local ablative therapy. The follow-up prostate biopsy is done according to the active surveillance follow-up protocol.
Sir, what is the role of PCA3 in the diagnostic of?
First of all, it is not available in our setting. And secondly, it is again not used as a clinical tool in most of the centers around the world. So you can't find PCA3 maybe in the guidelines. Somewhere it is written, but not in the mainstream. The second point I want to mention is, if you go back to the various isoforms of PSA, the value of different kinds of isoforms and taking into considerations all those is in the form of PHI, that is Prostate Health Index. So the Prostate Health Index takes into account all these isoforms, and not only they quantify these isoforms, but also the goal or the objective of having all of them into a single calculation is to make you or any clinician slightly in a comfortable position to decide whether the person needs a proper biopsy. And the biopsy would always yielding a good result. Good result means a positive or a negative result that you can rely upon. So in order to increase the yield of biopsy, these calculations are actually done. But again, they need a little bit of investment in the laboratory setting. So they need a little bit of understanding. And in many parts of the world, PHI is still in use. So earlier it was mentioned, I think 10 years, maybe 15 years back in the literature, and then it wasn't made a kind of a regular practice. But if you see the literature in the recent past, that is 6 months or 1 year from now, you can see articles addressing PHI and its value. So for us, still, the value remains at the PSA density point of view. But from that point of reference, if we have this kind of PHA into our perspective, our decision making and yield of positive biopsies would increase. The second point I want to mention is about the repeat biopsy. You see, the repeat biopsy has to be something which is not only made a practice, but also institutional. That means it should not be something which, for instance, I am more inclined to do a repeat biopsy, and one of my colleagues in the same clinic is not in the process of thinking that it shouldn't be done. It should be made a policy that everybody should do it. Unless and until we do it, we will not be able to pick that kind of a person who is somewhere down the line, maybe hidden in the bigger pool of BPH, right? So, for instance, if today is the prostate clinic, then the main aim of prostate clinic is not only to address the problems of lower urinary tract symptoms and bladder outlet obstruction, but it is also to pick those people or those patients who are in the bigger pool of BPH. Maybe they are harboring carcinoma. Maybe they are in the very early stages of carcinoma when there is no metastasis, there is no bony pain, there is nothing of the sort which can give you an inclination that the person has got probably a metastasis or a carcinoma. So it is something which is secretive. So you have to look into those kind of patients. For instance, if you want to have patients or biopsies having high-grade PIN, then you need all these repeat biopsies every now and then, just on the hunch or maybe on your clinical judgment that the patient's DRE is something which is abnormal, or maybe there is PSA velocity which is on a higher scale. So these are the things which makes you slightly more active towards one person as compared to the other person.
So preparation for biopsy, patient should be informed for the risks and benefits of procedure, and informed consent should be taken. Anticoagulation therapy, for example, warfarin, clopidogrel, should be stopped 7 to 10 days before prostate biopsy. For patients at increased risk of thromboembolic events or having mechanical valves, on warfarin, bridging anticoagulation with unfractionated heparin or low molecular weight heparin is suggested. We also take rectal swabs these days to identify the pathogen. Patients who have cardiac valves or prosthetic implants should be given vancomycin shot before the procedure. And a small amount of urine in the bladder is very useful for the biopsy. This helps facilitate the examination by demonstrating the prostatic bladder junction. In 2014, updated latest to AUA practice, best practice policy recommended antibiotics for prostate biopsy include fluoroquinolones, first, second, third generation, cephalosporins, and aminoglycosides. Cleansing enema decreases the amount of feces in the rectum, thereby producing a superior acoustic window for prostatic imaging. Analgesia is very important. A local prostatic block is achieved using 1 to 2% lidocaine. A long spinal needle 7 inches long, 22 gauge bore, and truss guidance along the biopsy channel of the transducer. Multiple variations exist for the infiltration of local anesthesia for transrectal biopsy. It is found that injecting 5 ml of lidocaine at the level of seminal vesicles near the bladder base at the hyperechoic fat pad that demarcates the junction of seminal vesicles and the prostate bilaterally produces an excellent block. Other approaches include infiltration of 10 ml starting at the junction of seminal vesicles and infiltrating along the lateral aspect of the prostate from base to apex. In the settings of saturation biopsy, it is known almost 20 ml lidocaine is used, in which the local is infiltrated in the prostatic parenchyma. This also gives very good analgesia. Patient lies in the left lateral decubitus position. Patients to examine, and we have to see both the transverse and the sagittal planes. In the transverse plane, imaging with end fire, side fire, and some biplane modes is accomplished by angling the handle of the probe right or left using the anal sphincter as a fulcrum. With radial and some biplane probes, advancing the probe cephalad into the rectum images the prostate base, the seminal vesicles, and the bladder neck. Pulling the probe caudally towards the anal sphincter yields images of prostatic apex and proximal urethra. Now for the sagittal plane, if you're using the side fire probes, clockwise rotation yields images of the left side of the prostate, and counterclockwise rotation yields images of the right side. Using an end fire probe, sagittal imaging can be accomplished by angling the probe up and down using the anal sphincter as a fulcrum. In the left lateral position, angling the handle of the probe down towards the floor yields the images of the right side of the prostate, and angling the probe up towards the ceiling yields images of the left side. So can anybody tell what planes are these? This in the diagram 1 and 2. what are these views when we see in the truss?
I think it would be difficult for everybody to understand, particularly the junior colleagues. You see, the whole paradigm is whenever you start evaluating something, assessing someone, then it drives learning. For instance, whenever at the college level or at the examination level, we start asking people on talks that they have to perform ultrasound of the kidneys, then the students, all of the students that appear for talks, they know how to do at least measure the kidney, visualize the kidney, and maybe point out where the actual lesion is. Now, the second step would be that you want to access the kidney through upper pole, lower pole, that is upper calyx, middle calyx, or lower one. That will be followed then with the biopsy. How would you take the biopsy from the kidney? Now, once the kidney protocol is over, I'm talking about the examination, then we'll probably go towards prostate. Definitely will go towards prostate. Now, the problem with prostate is many of the centers in our country, they don't have the transrectal probe, but that is an excuse which cannot be taken as such because we have to progress as a country, as a nation. So once we ask somebody to have the knowledge of using a transrectal probe, then the students will learn how to have images or how to differentiate images which are transverse as compared to the longitudinal. A unipolar probe, a uniplanar probe, and a biplanar probe, these are the differences that they can learn at that point in time. The third point would be to measure the prostatic volume to know where the actual hypo-iso or hyperechogenicity is. And the final would then be how to take a biopsy of the prostate. Once that is achieved, then we'll start having prostatic biopsies by the surgeons themselves because they want to do something called prostatic work. They want to do something called radical prostatectomy. And nowadays, surgeons take biopsies themselves all over the world. So revolutions don't come in medicine. It has to be an evolution. So the evolutionary process, as I have said, has to be stepwise. So we'll take everybody along. It will take probably maybe more time, but finally we'll reach, and we have got that kind of objective in our sight, that where the faculty has to move and take everybody, not only all those who are sitting in this room, but all those who are sitting outside in various cities of this country. All of those students have to go same path, whether they are pursuing fellowship or master's degree.
So just generally, this is the transverse image, and this is the sagittal image. Here you can see the bladder, and this hypoechoic area shows urethra. This is the sagittal image. This line, this dotted line, tells the longitudinal dimension of the prostate, whereas this dotted line tells the anteroposterior diameter. Spring-driven 18-gauge needle core biopsy device or biopsy gun can be passed through the needle guide attached to the ultrasound probe. The biopsy gun advances the needle 0.5 centimeter and samples the subsequent 1.5 centimeter of the tissue, with the tip extending 0.5 centimeter beyond the area sampled. So when sampling the peripheral zone, the needle tip may be placed 0.5 centimeter posterior to the prostatic capsule before firing. Advancing the needle to or through the capsule can result in sampling of more anterior tissue, missing the most common locations of the cancers, which are peripheral areas. Avoiding adjustment of the probe position while biopsy needle is in contact with the rectal surface and applying pressure with the probe to compress the rectal mucosa before biopsy can minimize rectal bleeding. You can also press the probe against the rectums or to minimize the discomfort of the biopsy needle traversing the rectal mucosa, just similar to pulling the skin tight to minimize the discomfort of phlebotomy.
Now, interestingly, if you change the gauge of the needle, for instance, from 18 gauge to 16 gauge, your biopsy material would be a slightly more, and you will have more capacity to say something about the tissue. So it's a very interesting subject, and everybody who is in the game of it has to know what this biopsy needle and how it is worked. For instance, at this time, we have got biopsy gun, and since it is spring loaded, so you can't have different kind of pressures or forces applied by different people. So it is the same pressure whether you apply or I apply or somebody else who is an expert can apply. So now everything is standardized. What remains is something which is an abnormal area that can be seen in real time through ultrasound. So maybe there is an area which I think as a surgeon, because I have done the DRE, that this is an abnormal area. So I want to go towards maybe the right lobe of the prostate. Now that information is actually not available to a radiologist who is doing it. You see, if the clinician or the surgeon does it, that is the biopsy, there will be more information available to him. There is more, say, we have got more obsession towards it. So this is something which we own rather. So it's the ownership which is towards the surgeon rather than towards the radiologist. Radiologist is actually masked from the history of the patient. Maybe the history is there, but he hasn't done the examination himself or herself. But it is something which is a prerogative of a clinician. So if a clinician does it, then it would be a very different ball game. You see, so that is something which everybody has learned all over the world, and that is something which we have to learn here in this part of the world.
So for the biopsy purpose, we have to be familiar with the truss as well, because we have to manipulate the probe and
it's not difficult. You see why I'm advocating and why I'm debating about it, because 25 years back, I have done it. And 25 years back, this was something which was introduced. And since it was a part of my dissertation at that point in time, so in 1995, if I can do it without any training, proper training, you can do a better job with a proper training, right? So it's not something which is difficult. It's not something which you cannot learn. It is something which can be learned within a few days, maybe 1 or 2 days. That's it. It's not a big learning curve that you want to just climb upon. मैं सीख सकता हूँ तो हर आदमी सीख सकता है.
So this is certainly not the probe you're going to use. So this is the image of the transrectal ultrasound probe. It is usually worn by a condom, and there is this needle which is fixed, needle device that is fixed on the probe. It has a path through which the needle can be progressed and the biopsy is taken.
So sorry, एक और चीज शेयर कर दूं आपसे, सिखाएगा कोई भी नहीं आपको. अगर 1995 की स्टोरी में रिपीट करूं तो रेडियोलॉजिस्ट ने मुझे भी नहीं सिखाया था, मुझे कमरे से बाहर निकाल दिया था इसी इंस्टीट्यूट के अंदर, ठीक है. लेकिन मैंने सीखा क्यों था? इसलिए कि वो मुझे डिसर्टेशन का हिस्सा था मेरे, तो मुझे तो करना था बाय हुक और क्रोक. इफ नॉट इन दिस इंस्टीट्यूट मैं कहीं और चला जाता सीखने के लिए. सो आपके पास ना एक स्पार्क होना चाहिए to know something. If you want to know something and you see that there is a value for it, then you will go to any length. कहीं पे भी चले जाएंगे आप, जाके सीखेंगे, यहाँ सीखेंगे, कहीं और सीखेंगे. लेकिन इसको सीखना जरूरी है. सारी दुनिया कर चुकी है, हमने नहीं किया सर. ठीक है.
So here are different techniques which are used for the biopsy. The sextant biopsy technique was first came in 1989. They used to take 6 samples. The area above the diagram that shows the base of the prostate, the middle zone, and here's the apex. So But today, the extended 12-course systemic biopsy that incorporates apical and far lateral cores in the template distribution allows maximal center cancer detection and avoidance of a repeat biopsy while minimizing the detection of insignificant prostate cancers. So double sextant biopsy came up in practice after 2013 and 14. You can see different areas of the prostate labeled as dots where the biopsy is taken. Saturation biopsy involves 18 to up to 21 cores. Well, we have some patients who have a negative prostate biopsy, but yet rising PSA levels. So in a study of 57 men with an average of 2 prior negative sextant biopsies, a cancer detection rate of 30% was obtained with an average of 22.5 cores per patient. When performing repeat biopsy, attention should be placed on the apex, which may not be adequately sampled by truss biopsy. A drawback to these techniques is that additional anesthetic requirements are required to be, so it's difficult for them to be done and look in like OPD setting. So there are very few contraindications to prostatic biopsy, which involve severe coagulopathy, severe immunosuppression, or if the patient is having acute prostatitis. The complications include hematospermia, hematuria, rectal bleeding, prostatitis, fever exceeding 101.3 Fahrenheit, epididymitis, urinary retention, excessive anxiety may also trigger the vasovagal response. The other types include the transperineal biopsy used in patients without a rectum, underwent surgical extirpation, or who have congenital anomaly. It requires more use of local anesthesia, but it has reduced risks of infection. Increased detection of the apical tumors, and it's done in lithotomy position instead of the left lateral decubitus. Transurethral biopsies are mostly used to take the biopsy of transition zone.
So one thing should be clear, and that has been again cleared in recent times in literature. For instance, if we call truss-guided biopsy as a transrectal biopsy, then again transperineal biopsy is also transrectal guided biopsy. You see, the guidance is through transrectal route. The probe is in the rectum. Whether you go through the rectum, the needle goes through the rectum, or the needle goes through the perineum. So if it goes through the perineum, then again it is transrectal ultrasound guided biopsy, right? So the guidance is through the truss, that is transrectal ultrasound. The other that is transrectal biopsy is now called transfecal biopsy because it is going through the fecal route. So one is through the fecal route, the other one transurethral is through the urinary route, and third one is transperineal. But the guidance for the above two, that is transperineal as well as transrectal, is through the transrectal route, and that is the transrectal probe. कभी कभी हम उसको मिक्स कर जाते हैं, तो वो बिल्कुल क्लियर होना चाहिए हमारे जहन में. इसीलिए वो अब लिटरेचर में उसको ट्रांसफीकल कहते हैं, उसको ट्रांसपेरिनियल कहते हैं.
And lastly comes the Gleason score. So pathologists assign a primary grade to the pattern of the cancer that is most commonly observed and a secondary grade to the second most commonly observed pattern in the specimen. Grades traditionally ranged from 1 to 5. If the entire specimen has only one pattern present, both the primary and the secondary grades are reported as the same grade, for example, 3+3. The Gleason score or Gleason sum is obtained by adding the primary and the secondary grades together. However, pathology grading practices have changed over time and such that Gleason pattern 1 and 2 are rarely assigned. So Gleason pattern 3 corresponds to low-grade disease, pattern 4 corresponds to intermediate grade, and pattern 5 corresponds to high-grade disease. So here you can see the arrangement of glands in this image. The uppermost is grade pattern 1. It has small uniform glands. Then comes involvement of stroma into the glands. The glands become dispersed. And pattern 3, there are distinctly infiltrative margins. In pattern 4, we have irregular masses of neoplastic glands, and in pattern 5, we can see no glands. So again, the Gleason pattern 3, we can see variable sized glands that percolate through normal stroma and between normal glands. It's a low-grade disease. You can see this formation of round glandular structures. Then comes the cribriform or poorly formed fused glands, incompletely formed glands with variable amounts of fusion and more infiltrative growth pattern. You can see clusters of these glands coming together. This is Gleason pattern 4, and the variations that we see in prostate biopsy are cribriform patterns and comedocarcinoma. They also come under this pattern 4 disease. Then we have Gleason pattern 5, where we have single infiltrating cells with no gland formations, and it's a high-grade disease. So Gleason score 6 is Gleason grade 1, and it's less aggressive, slow-growing, low risk. Gleason score 7, 3 plus 4 is group 2, slightly aggressive, slow-growing, and low to intermediate risk. The Gleason score 7, that is 4 plus 3, the primary pattern is 4, and the secondary pattern being 3, is grade 3, moderately aggressive, fast-growing, intermediate to high risk. The Gleason score 8, that is 4 plus 3, either 5 plus 3, is grade 4, aggressive, rapidly growing, and high risk. Gleason score 9 or 10 comes in grade 5. It is very highly aggressive, rapidly growing, and a high-risk disease. Then
so these days, we don't express Gleason score as 6 or 7 or 8 or 10 or 9, but we express them as a Gleason grouping, that is a grade grouping, 1 grade grouping. So GG1, GG2, GG3, and so on. And you cannot have somebody who is less than 6. So the starting point is 6. So if you have got grade 1, grade group 1, then you can just put the patient on surveillance. But the actual disease progression or management starts from grade grouping 2 and 3. And here the actual management division lies, because both are 7, but one is 3 plus 4 and the other one is 4 plus 3. So the primary grades are different. Since the primary grades are different, so they are grouped differently, and they have got different kind of projections as well as stratifications and evolutions later in life. So it is very important to know the nomenclature which is recently used, because now if you stand up in front of somebody and you are explaining your patient, and the person happens to be a knowledgeable person, he won't ask you the Gleason score, he would ask you the Gleason grade grouping. Right.
Right. And then we also have this concept of tertiary pattern in settings of patients whose PSA levels rises, or in cases of relapse. They have seen in the radical prostatectomy samples that a third most prevailing grade was also found in the specimen. Like if the third most prevailing sample is 5, then it is very important. And
the volumetric analysis is then comes into play.
The TNM staging of prostate is very easy. The T1 disease, if you cannot feel the cancer on DRE, it's a T1 disease. If you can feel the cancer on DRE, it's a T2 disease. T1 disease, you cannot feel on DRE, then you have come to know about this cancer on the resected tissue that you have done after transurethral resection. If the less than equal to 5% of the resected tissue has cancer, it's T1A. If more than 5% of the resected tissue has cancer, it's T1B. And if the cancer is detected by elevated PSA alone and a normal DRE, then it's T1C. If you can palpate the prostate, it's a T2 disease. If it involves less than half of one lobe, it's T2A. If it involves more than half of one lobe, it's T2B. And if it involves both lobes, it's T2C. If there is extracapsular extension on one or both sides, it becomes T3A disease. And if seminal vesicles get involved, it becomes T3B disease. T4 disease, the tumor extends into bladder, neck, sphincter, rectum, levator muscles, or into pelvic side wall. The N classification is dependent on the size of the nodes, that is less than 2 to 5, or greater than 5 centimeters. Metastasis in single regional lymph node of less than equal to 2 centimeters in dimension is N1. Metastasis in single more than 2 but less than 5, or multiple with none more than 5 is N2. Metastasis in regional lymph nodes of more than 5 centimeters in dimension is N3 disease. M1A is distant mets in non-regional lymph nodes. If it gets into bone, it's M1B, and if it gets to other sites, it becomes M1C. Thank you.